All right, I am going to get started so you can get out of here sooner. Hopefully that'll be okay with everybody. My disclaimer is that I am making this copyright free so that we can post it on Louisville Lectures without a lot of editing, which means I can't be as funny as I wanted. I can't put a lot of memes and videos in, so just pretend that I'm funny, okay? And I've got, so we're going to have, my other disclosure is that I'm not getting paid for anything. I do research that includes the Good Days Ahead program that we're going to talk about, but nobody pays me anything. And hopefully what you can take away from what we talk about today is that depression affects everybody, which I think you already know, but kind of some data behind that. And then the screening tools that are available, how you can use them and use them efficiently, and then what do you do when you get a positive screen. And then you're going to learn a little bit about the study that we have ongoing that you can refer patients to in your AIM clinics. And even if you're in the hospital and somebody follows with a U of L outpatient clinic, you can refer them there even if you don't have an AIM clinic like our MedPeds residents. So I think everybody cares about depression. It's just really hard to fit into a busy primary care world. But when you think about it, and actually I do have another study I'm going to talk about that covers depression in residents and doctors. So it's prevalent for all of us. 1 in 5 Americans will experience a mood disorder, whether that's depression or something else on the spectrum. And it really impacts our society. So 43 billion can sound kind of abstract, but that's how much U.S. medical care is associated annually with depression. That's direct association. That has nothing to do with how many of our patients that we see that come in time after time because they probably have underlying mental illness and aren't adhering to their diabetic regimen. So if you think about 43 billion, and it does seem abstract, I want you to see if you can remember where Slovenia is, and I couldn't, but it's the gross domestic income for Slovenia that's estimated for 2017. So when I Googled Slovenia, I had to add a couple of new images to my Pinterest board because I'd really like to go there someday. It looks awesome. So if anybody's been to Slovenia, I'm going to hit you up later. Anybody? No? Okay. What was that? You've been there? All right, we're going to talk. I'll buy you a coffee or a beer. So looking at it, we're actually losing. So when we think about the 17 billion in lost productivity, and you look at it by disease, it would be tempting to say that people are losing more work time due to being in the hospital, having complications of other issues that we see all the time. And it's in fact depression that's the #1 cost by disease. So you can look at that journal if you're interested in more, but I was kind of shocked by that because I was actually shocked by heart disease being lower, so I'm wondering if the people with heart disease have already been on unemployment, so it's not causing it. I have to read that study again because I was curious about why heart disease was lower than the rest. So what are the most common diagnoses that you think you see on a call day? Shout them out. COPD, altered mental status. Chest pain, sepsis, drugs. Yep, those are all good ones. So this is what I thought of: the heart stuff, diabetes. I think I forgot the respiratory, falls, altered mental status, ingestions, and substance abuse. So I could directly find studies that tied depression to heart disease and to diabetes and to falls. And of course there's tons of data out there on substance abuse and depression. So this was an interesting one. They actually took 1,200 male medical students between about 1950 and 1965, and they followed them for 40 years. And they saw that 12% of them were diagnosed with depression during those 40 years. And then they said, well, they have other things going on that are probably making it worse. So they looked at substance abuse, they looked at cigarette smoking, they looked at actually caffeine intake, and the only one that was associated with increased risk of cardiovascular disease in the people with depression versus the ones that weren't was it's actually caffeine intake. So the depressed people use more caffeine. But when you look at the all-cause, when you look here, you can definitely see that when you compare with the depression versus those without the depression, it's pretty obvious that even when they've tried to adjust for when they graduated, were they older when they graduated medical school, maybe that's going to age them out of the general population. And they looked at cholesterol, family history, physical activity, so that just the couch potatoes weren't the ones that were depressed and the ones that were getting heart disease. So that one interested me because it was actually looking at medical students. And then more problems. So this was a meta-analysis looking at complications of diabetes and associating those with depression. And you can see the effect sizes are the R's here, and then it's in a 95% confidence interval when you cap that off there. So I think we all know that depression is important, and we want to screen for it. And we know that this is the formal DSM diagnosis, which is a lot. So that's a lot to ask, and that's a lot to pick up, and a lot of other things can make you have a couple of these symptoms. And so it's really hard to treat because people don't talk about it, and we don't ask about it enough. And then people don't want to complain about it. Even when they're getting treatments, it's hard for people to get time off of work. And then even when we start treating them, 15% are never going to get better, and 35% might get better for a period of time and then get worse. So primary care really is, I think, the gateway for this, and screening in primary care is so important. That's why the United States Preventative Service Task Force recommends screening in 12 years and up everybody. But then they also have the caveat in clinical practices with systems to assure effective diagnosis, treatment, and follow-up. So if you don't have a good system, are you not supposed to screen? I don't think that's true, but I thought that it was interesting to think through why our patients don't get screened more, and we're actually doing a great job now. We have a PHQ-9 at our AIM clinic and our attending-only clinic. I don't know if those of you who go to private clinics in the MedPeace world, if anybody is doing a screening intake for this, but we're going to talk a little bit about those. But we see a lot of the people we see have depression, and we're going to be the primary people handling their depression. I bet there's a lot of people out there that are your patients, that you are the person who is prescribing medicines and dealing with their depression primarily. And we don't catch it often. This is from the PHQ-9 study that came out right around 1999, and they looked at how many misdiagnoses that we had, and they compared it to using diagnoses from an actual sitting down and interviewing a patient and going through that with the PRIME questionnaire. So we're missing it a lot. So the answer would be, like anything else, we screen, then we confirm. So here are some of the screening scales for depression, and then there's diagnostic scales. So you would run people through one of these on the top, and then so hopefully that could be something that they could fill out on paper, and then if they flag, you can run them through the one on the bottom. The ones that we use the most are PHQ-2 and PHQ-9. So somebody comes into your office, and these two questions, if you have a suspicion, you can ask. If you ask these two questions, it's a really good sensitivity and specificity if you are combining them. The sensitivity is better, of course, because it doesn't specifically mean that they're depressed, but it's definitely a positive screen, so then you can move to the PHQ-9. You guys can Google the MedCalc PHQ-9 right now on your phones if you want to take it. If you have a QR code, you can scan here, but these are all of the questions. We can find out if you need help right now. So it seems pretty simple. We get a positive screen. So then we do the PHQ-9. It's positive. We think they have depression or they have depressive symptoms. So we're going to screen for a couple of other things and make sure there isn't another psychiatric issue. They've never had mania. The other things here, when we look back at this, we want to make sure there's no mania or hypomania. We make sure they're not suicidal, and then we're going to prescribe them a medicine maybe after we talk to them and figure that out. So we're going to write sertraline. We can follow them back, and the nice thing about the PHQ-9 is you can continue to check it as they continue to come back into clinic, so you can see how effective your therapy is. You might refer them to like outpatient counseling or psychology, which may take them a while to get into, maybe 2 to 4 months, I think is what we're running right now at UL. So maybe sooner, maybe not so soon. It really depends on the patient and their work. So we're tracking that PHQ-9, and it turns out that when we look at just using our medications, this is a meta-analysis that looked at this, and there's hundreds of studies that show that they're very effective, and they're very effective for relapse prevention. But when you look at mild to moderate depression, which is probably the people that we're going to pick up when we screen, they're not the people that walk in and you can tell they're depressed, or the people that come in complaining of depression. For those mild and moderate ones, they're only showing very little change from placebo, and it's not statistically significant. So that's where you really want to combine, and there's great evidence for CBT plus medications, but CBT is something that is difficult for anyone. I doubt that I can make it to CBT with my schedule during the day, much less our patients who have poor means of getting there. They don't have a way to pay for it. So we're going to hear a little bit more about CBT because I don't do it in my practice. So Sara Williams is going to share with us a little bit more about that.
Thank you, Dr. Bishop. So I'm Sara Williams. I'm the Senior Research Associate for this grant. I'm just going to tell you a little bit about cognitive behavior therapy and computer-assisted cognitive behavior therapy for depression. So CBT is one of the most heavily researched forms of psychotherapy with over 300 randomized control trials. And it is based primarily on information processing model. So Aaron Beck was one of the originators of CBT, and he posited that information processing is altered when we're depressed or anxious or have any of these other mood disorders, and that we are more likely to appraise things as negative than we would be when we're not depressed. And so CBT itself is probably problem-oriented, and it's usually short-term, so anywhere between 5 and 20 lessons. And it's very collaborative and action-oriented. So despite the common misconceptions about CBT, it's not just looking in a book and providing that for therapy. You actually do a bunch of collaborative work with your patients. It uses a lot of self-help and homework, and it helps build skills to overcome symptoms of depression in the future. And so it's made up of cognitive and behavioral components. So the cognitive part is pretty much that your thoughts impact your feelings and your behaviors, which then in turn impact your thoughts again. So it kind of exists in this very fun cycle in which you are always appraising things to be much more negative than they actually are. The little yellow cartoon is actually an illustration of Beck's negative cognitive triad, however you say that. And basically that says that when you have this negative cognitive triad, you're looking at yourself, the world around you, and the future in a very negative light. And then the behavioral components. So most people, when they think of behavioral conditioning, they think of Pavlov. So I put this little dog up here because dogs are cute and they're fun. So the behavioral part of CBT did originate with the Pavlov and Skinner experiments from the 50s and 60s. And they continue on to now. We use them in CBT to alleviate symptoms and move towards better cognitive appraisals. So this is the basic CBT model, and it's kind of a very circular model, as you can see, in that our emotions and our thoughts impact our behavior, which then impacts our emotions and then our thoughts. And as we know, depression isn't limited to just thoughts and emotions and our behaviors. There are also a lot of other things that go into depression, like the physiological stuff that I don't know quite as much about as you guys do. But we know that it's not limited to just cognitions and emotions. So we do take those things into account and acknowledge that the cognitive and behavioral interventions are moderated through the physiological and medications type stuff. So there are 3 levels of thinking, and those are consciousness, which is the highest one, and that's when we're kind of able to make rational decisions and stop and think about things. And there's automatic thoughts, which are the primary focus of a lot of this work in CBT, and those occur rapidly. They don't go through any kind of filter or anything. They just immediately pop up, and they're usually private. And one of the best ways to kind of recognize a negative automatic thought is a spike in emotion. And then there's schemas, which are kind of the most core type of thinking, and those essentially act as filters through which we process all the information around us. So they usually develop in childhood, and then they continue to develop as we grow. People with depression are more likely to have cognitive errors, which means that we don't process things the same as we would when we're not depressed. And so a lot of these negative errors are learned through the CBT curriculum, and they are what kind of help us get past the negative thoughts and moving on to something better. Suicide is as you all know, a very big problem right now, and it's the second leading cause of death among people 15 to 34. And depression has been associated with suicide and hopelessness in general. And CBT has been found to be very effective in reducing that hopelessness and building hope to prevent suicide. So there are key methods in CBT. Like I said before, it's problem-oriented, it's very individualized and collaborative. You use a lot of Socratic questioning to kind of help the patients learn what you're teaching them, as opposed to just kind of lecturing and then hoping they take it in. There's a lot of structure and psychoeducation, and then a lot of thought work coupled with some behavioral activation techniques to kind of increase mood and agency. So because CBT and other traditional forms of psychotherapy can be very difficult for patients to access due to cost and availability, time, transportation, and all of that, we are moving towards a computer-assisted CBT model, and that is what our current study is on. So I'm just going to play a little video that kind of introduces the software program that we use, and it's called Good Days Ahead. So Good Days Ahead is the computer software program that we use. I'm going to let this play just because it does show some of the screens and stuff. And essentially, Good Days Ahead is a 9-lesson program that the patients would do when they're enrolled in our study and randomized into the treatment group. They would do this 9-lesson program in addition to working with our care coordinator, personal coach, for 12 weeks. And so since there are 9 lessons in 12 weeks, there tends to be some overlap, especially with some of the more complicated lessons. The further along in the program you get, the kind of deeper you go. So sometimes we spend more time on the more complex lessons. But overall, Good Days Ahead is fairly user-friendly. We haven't had too many issues with the software itself. Technology is a whole other story. Lots of issues there, but I play tech support, so that's fine. That's one of the kind of the biggest concerns that we see with patients is that they're concerned about using the computers or the technology, but we make everything as user-friendly as possible, and we're very willing to be flexible in working with them to make them feel a little bit more comfortable with the technology that we use. So that was the end of the video. So we're using computers to help assist in therapy because it's much more cost effective for the provider and for the patient. So they're not having to pay $7,500, $200 a week to go to therapy. It doesn't take an hour out of our time. Our sessions are only 20 minutes and they're done over the phone. So that reduces travel and appointments and all of that. There are experiences that just aren't really possible or practical in standard therapy, like interactive quizzes and activities, exercises, and videos that kind of illustrate the concepts that are going through. And then the program also provides more education than would be practical for us to do in a therapeutic setting. So we don't want to spend the entire session talking about things and trying to teach things. We want to work through some of the skills that they need to do, and that can be facilitated through the use of the computer program. In addition, it allows us to collect and manage data so we can track progress and see how effective the computer program is, as well as seeing if the therapy is working for that patient. This is from the preliminary study, which was done in a psychiatric setting as compared to this one, which is done in a primary care setting. And results show that CCBT was pretty much just as effective as CBT when there was a support component. So when there wasn't clinician support, it wasn't quite as effective, but the comprehension of CBT concepts was more effective with the computerized version. This just shows the comparison from the last study on the Hamilton Rating Scale, which is another depression scale. And this blue line up here is the wait list, and then the black line is regular standard cognitive therapy, and then the red line is computer-assisted cognitive behavior therapy. So you can see that the scores that follow up especially were a lot lower. We don't know if that was simply because they learned and were able to apply the techniques better, or if it was just an anomaly because there wasn't as big of a gap at 6-month follow-up. So now that we've done the psychiatric setting, we are doing, no, this is the psychiatric setting. Yeah. So now that one has done, that one just got accepted and showed really good results, we're now doing a primary care dissemination study. And so some kind of more easy ways, I guess, to recognize depression than asking about thoughts and stuff like that when you're seeing your patients are just the behavioral changes, like decreased activity levels, like Dr. Bishop said, asking about interest in things and just overall kind of feeling sad over the past month or 2 weeks, but also kind of withdrawing from friends and family, a lot of procrastination and reduced problem-solving type behaviors are very common when people are depressed. And then we work a lot with automatic thoughts and CBT, and kind of work to recognize when we're having maladaptive automatic thoughts to try to modify those to make them more adaptive so that they're not quite as distressing. Okay, so the current study, we have 4 different sites. 3 of them are here in Louisville, and 1 is down in Glasgow, Kentucky. And we're doing that just to see how it rolls out in the city versus the country. So the AIM clinics are considered 1 site for us, and then the other 2 are other University of Louisville medical practices. And so we're looking at whether or not Good Days Ahead, coupled with treatment as usual, so the kind of treatment you would already give patients regardless, has any outcome on depressive symptoms, overall quality of life. And we'll also be doing a cost-benefit analysis. So we're hoping to have between 240 and 320 patients enrolled total over the course of the study. And we'll also be looking at epigenetics. So we're looking at the processing of cortisol and pre and post and follow-up. All right, I talked a little bit about how that works. So there's 12 weeks of an active treatment phase, and then we do follow-ups at 3 months and 6 months. So really what your role would be in this is just to kind of take in the information that we're sharing with you today and be able to tell your patients about the program and just kind of assess to see if they would be interested in that, and then referring them to me. We'll give you some pocket cards so that you'll have more information about the study. And you don't have to remember everything or write everything down. We have those for you. And so this slide is probably one of the most important ones for you because it's the inclusion and exclusion criteria. So in order to be in our study, they have to be at least 18 years of age or older, and they have to have a PHQ-9 score of 10 or above. If you don't get the PHQ-9 score for whatever reason, or if they're not diagnostically meeting the standards for depression, you can still refer them to us. We'll do that screening part. So even if they just have symptoms of depression or they're complaining of symptoms of depression, you can go ahead and refer them, and then we'll do the full screening. They have to be able to read and speak English. It doesn't have to be at a very high level. They just have to feel comfortable enough reading the computer to be able to benefit from that. And then the exclusion criteria, there can't be any history of bipolar disorder or psychosis, no significant suicidal thoughts, intent or plan. That's another thing we'll screen for. So if you're not sure, you can still send them over to me and I'll figure that out. No current substance abuse or dependence. No severe or poorly controlled medical condition that would impede with their participation, and no dementia or other kind of brain or organic brain or cognitive disorders.
I was just going to say, when I have patients that maybe they're currently on depression medicines or they've not been actively treated, and we're discussing it for the first time because they had a positive PHQ-9 as they came in, I will ask them and we'll start to talk about their depression, and I'll just offer it and I explain it pretty simply, and we have some sample scripts on those pages that she's going to give you. But it's just, we have a program here. I know that it's hard for some people to make appointments really frequently. What we've seen in studies is that doing a certain type of therapy in addition to doing the medicine works better than either one alone. So I have a computer program that we're using now that can help you to do some of that work at home. Would you be interested in talking to somebody more to figure out if that's going to be a good fit for you? And then they're going to say yes or no or maybe, or I need more information. And you can say, well, why don't I just, I have somebody who does a study, and I'm going to go ahead and, if it's okay with you, I'll give her your info and she can call you on the phone and you guys can talk about it and see if you want to hear more. And that's how it goes for me. So it's very I don't have to get into what CBT is. And It's literally, there's a program on the computer. Could that be right for you or not?
And you can give them my information too. If they're not comfortable with you giving me their information, you can just give them my number. If they decide they want to do it, they will contact me.
Questions?
Any questions?
I think Dr. Casper was updating me on this a couple weeks ago. Are we able to actually get people computers if they don't have one at home?
Yes, we have loaner computers. They're just little Chromebooks. They're really user-friendly. But yes, we do have those. And we also have portable Wi-Fi networks. So if they don't have Wi-Fi at home, we can set them up with that.
Great.
And our patients do receive a stipend for kind of their troubles and time.
And this is specifically for depression, right? This is not CBT geared towards anxiety or any other...
Correct, just for depression.
Yeah.
They can be absolutely comorbid, though. If they have... even they don't have to meet diagnostic criteria for depression. So if they have symptoms of anxiety that are also depression, send them on over and we'll figure it out.
Yeah, and that's what I like about it, that you can do our clinic should be doing the PHQ-9 before you see them, so it should flag for you if they're positive. And if you just do a PHQ-2 and you're concerned and they have depressive symptoms and nothing obviously that's standing out to you, just have the discussion and send them Sarah's way and she'll figure it out.